Thank you, everybody. Good afternoon. I really appreciate that all of you are here and sharing your time. Thank you, Dräger, for making it possible. And the first thing I want to say, I don't want to bother any of you, but I'm going to be provocative. And just to make you try to make you think. So this is my conflict of interest. I don't have any conflict of interest in this church, in this lecture, except that I want you to make think. And this is going to be probably suffering. So the agenda for today, we are going to cover two main topics. The first one, the use of VO2. I don't know if you are aware about this, but there is a huge problem now about neonates and preterm babies. What is the VO2 that we have to use it? And after that, what is the main respiratory difference between a child and an adult? Just like a sum up and take home message for all of you. The first thing I want from you is how many of you are pediatric anesthesiologists? Well, not bad, not bad. Because sometimes when I do this question, there's only 3 or 4 of us. So it's like a extinguished species in anesthesia. How many of you have ever tried to do anesthesia, pediatric anesthesia in your life? Okay, well, good. So let's go for that. Just in case I have another plan, no worries about that. So I'm going to go for VO2. This is one of the most key paper in the world of neonatologists. By far, the most reference paper. We all know this paper about the retinopathy of the patients when you give a high doses of VO2. But this paper, in those days, I'm talking about 1960, so quite a long time ago, oxygen was in fashion. Wow, oxygen is the best molecule. You have to give a lot of oxygen to everybody. But this paper study, population study, is like a preterm baby, no distress, that they gave more than 50 oxygen to all of them. Even some of them receive oxygen up to 80 without any need. Because in those days, oxygen was amazing. And the rest of the population only receive extra oxygen if you need it, according to the oximetry and pulsioximetry. So, well, after this paper, everything changed. Because this guy was a very important person. He was the president of Neonatology Society in those days. So they create guidelines. And they say, from now on, never, ever, ever give more than VO2 in a neonate of more than 40. Yeah, but someone started to study mortality 5 years later. As you can see, read here, is 5 years later, everybody was never, ever give more than 40 of VO2, even if the patient was desaturated. See what happened with mortality 5 years later. 20% more of mortality. But there was a specific study, Lancet 1974, that showed to us that in these days, with the fashion, everybody's giving 40, 40, 40, 40. And he studied mortality in the United Kingdom and in the States. And they showed to us that this is the curve mortality. Whenever you start to reduce, extremely reduce oxygen, you increase mortality. This study showed to us that for this fashion, we expect to kill 150,000 children, 20,000 children. So, okay, that was those days. What is the guidelines of the last 4 years in the States for the use of VO2 in cardiac arrest in neonates? Exactly the same. We back 50 years ago. And as you can see here, internal infants receiving resuscitation at birth with positive pressure is best to begin with air rather than 100 oxygen. Rather than. Why you go from 100 that we studied is dangerous? Why now we have to go for 21? So I have a question for all of you. I want you to make you think. Imagine now we are go to Pisa Tower, go to the top, and you are going to throw, let then, two bowls, one plastic bowl and one iron bowl, and you throw it at the same time. I'm going to answer with you what I really thought the first time I saw this. How many of you think that the plastic bowl is going to rise the ground faster? How many of you think that the iron bowl is going to reach the ground faster? Okay? So I want you to hear this video.
Well, in my left hand I have a feather.
This is Captain Scott for Apollo 15 mission. He has a feather in one hand and a hammer in the other. And he's going to throw both of them at the same time at the moon.
And we thought that
this is the hammer and this is the feather.
To confirm his findings on the moon. And so we thought we'd try it here for you. The feather happens to be appropriately a falcon feather for our falcon. And I'll drop the two of them here and hopefully they'll hit the ground at the same time.
Done.
How about that?
So this happened because Aristoteles 2,000 years ago tell us that gravity it depends on the mass of the world bodies. And we eat it. We all eat it during 2,000 years. Until a person called Galileo say, let's go to have doubt, questions in our daily practice. Then I'm going to throw an apple and a ball and see what happened. And see the result and believe what you see. All of you are Galileos. Every time you go inside the operating room and do anesthesia, this is an experiment. The only thing you need is to observe, see what's happened, and doubt. Doubt, and every time you think you know something. And then you have to study and go for clinical trials. But doubt is clinical trials too. And then when you combine everything, you will improve. We are not going to be Newton that explain all this 300 years after the experiment. At least I'm not expect to be Newton. I expect to be good Galileo. So this is my message for today, and the most important thing I'm going to talk today, in my opinion, is this. Science is crucial on our life, but it's based not in our opinion. It's not based in our key leader opinion. It's based on the experiment. Okay, so let's continue with VO2. Let's try if we can apply this concept for VO2. You have this data, and this data is a huge amount of data telling us that if you use if you use more VO2, you decrease mortality, even in preterm babies. The second, this is a very nice study telling us that if you reduce VO2, obviously you reduce retinopathy, okay? Accept both sides. If you increase VO2, you reduce enterocolitis. Perfect, get this data. More data. Here again, if you reduce VO2 to 21 or less than 40, you increase death. More data. If you increase VO2 too much, you create bronchodysplasia. Data. Accept data. So once again, enterocolitis, if you give more oxygen, you reduce enterocolitis. Now, if you give very low or under 40 of VO2, you reduce retinopathy. So if we put all this data together, let's try to be and never lose clinical common sense. So use the minimal VO2 to obtain the target in oximetry and PO2. Now we know the targets have changed, and there's a lot of study telling us that if you go for very low objective in oximetry, you have more mortality. So preterm babies, now we know the objective is 1991 equals PO2 of 60. So use the minimal VO2, but obtain this objective. Second, neonates and children are objecting 94, 95, PO2 of 80, the minimum VO2, but obtain the objective. So what can we do besides the actual guidelines of neonates? I'm sorry to say that, but I'm totally convinced about this. is what to do in front of an acute hypoxemia event. You know what's happened? You get the guidelines from neonate for how to recover a neonate after the birth, and now I'm seeing with my eyes how pediatric anesthesiologists in front of a cardiac arrest or a hypoxemic event is saying, no, don't use more than 21. So the concept is clear, more than 70%, more retinopathy, more dysplasia. 21, more deaths and more enterocolitis. So never go for 70, more than 70, but never go for 21. So I always go for 75 when I have an acute hypoxemic event. And whenever I recover the child to 91, I go for the minimum that obtain the objective. Okay, so I finished this part. Wow, even faster than I was expected. And now I'm going to go to the second part of the lecture, that is sum up the main difference between children and adults. So I remember when I was just starting in mechanical ventilation in children. My background started in children, really. Now I've changed to adults 8 years ago. But I remember in those days that it was impossible to convince my colleagues to use PEEP in children, in neonates. No. Don't use PEEP because PEEP is very dangerous. It creates hemodynamic repercussion. So you can go for clinical trials. In children, there are not many. So you know what I did? I go for physiology. And I start to do research with isolated lungs. Why I love to work with isolated lungs? Because it's a perfect model for neonates and preterm babies. So the first thing I did was to do this research. This is one of the first I did in my life. So I put in front of me, with the same circuit, the same machine, everything the same, an adult lung, isolated adult lung, and a neonate, healthy neonate lung. And I try to visualize, see what you see is always true. To visualize how is the difference between one another. The first important thing, from the very beginning, you realize that like a neonate is fully collapsed. Every time you despressurize a lungs of a neonate, it goes for collapse completely. If you touch these lungs, it's exactly the same like liver. Just the opposite with adults. Adults, healthy adults, between 6 years and 25, 30 years, are very more stable than neonates. The second thing, I was always reading in all the textbooks, no, functional residual in children, neonates, functional residual capacity is lower, no, than the closing volume. And we eat it. And most of the book stay there. But they say, this is not, it cannot be true. How can, there's a problem, because if my functional residual capacity is lower than the closing volume, it means like the neonates, open, when they inspire, open the lungs, and during expiration, they close the lungs. Do you think like a neonate can open, close the lungs all the time? Then let's back to what? Physiology. A very nice book, 1988. Nobody studied physiology for all books. Books are there. Please, let's back to pulmonary physiology. And I found this reflex, glottic closure reflex. You know what they do? When they birth, what are the most collapsed lungs in the world? The one who never receive air. So a neonate, when it goes out from his mother, when the birth, are fully collapsed. What they do? Recruit it. They recruit the lungs. But if it's not in a stable lungs, what they do? PEEP, they create the glottic reflex. They close the glottis before the end of expiration. So just remember what my pediatric anesthesiologist told me. No PEEP, no PEEP, no PEEP. And now, if you don't have PEEP and I don't have PEEP, you die. No, we are not here as a species, human beings. So now we know, and it's measured, that we all need recruit maneuvers when you birth, and you need a minimum amount of PEEP to keep the lungs open. So next concept. Wow, 6 minutes. Compliance. Remember this because it's quite easy to remember. Children, the compliance is equals 1 milliliters per kilo. So whenever you have a children of 10 kilos, the compliance is 10. If you have a neonate of 3 kilos, the compliance is 3. What is the normal compliance of an adult of, let's say, 180 of 8? Neonates are very stuffed lungs, very restrictive and very low compliance. That's why it's so difficult to ventilate for any ventilator. And that's why in the old days, 10 years ago, 15 years ago, was so difficult to find good ventilator to ventilate these patients. Collapse. This is a very nice study from Dr. Joao Borges. This is a rabbit. This is a three-dimensional CT scan of a rabbit of 4 kilos. Between human beings, the lungs behave almost the same according with the weight. So you are here, the lungs of any child around 4 kilos. See, this is before the induction of anesthesia. And what you are seeing here is the negative of the lungs. So it's air. They extract the rest. But this is a rabbit breathing spontaneously. Someone came and put anesthesia. In 2 seconds, this is what happened. More than 30% of the area is fully collapsed. Always, always, always. Because it's pure physics. And law physics have a problem that is always the same. So, what you have to do? Recruit it. If it's collapsed, what is the best tool to reverse? Recruit it. But please, do it in the only way that now we know is safe. And there is only one way, that is pressure control. Every time I see a paper or a clinical randomized trial that allowed people to recruit in volume and really get nervous, for that, it's better not to do it. If you are going for volume control, how you are going to control the maximum pressure? You cannot. So then it can be dangerous. And then you will see more pneumothorax. Yeah? If you have bad indication and if you do it in a bad way, obviously you are going to find bad results. So now we know the pressure who are safe. Now we know the pressure that they are not safe. And we know the way to do it and the way not to do it. So now it's not recommended anymore to use CPAP. Now it's not recommended to use volume control anymore. The only way is constant driving pressure, pressure control. In children, please never ever go farther than 30 of maximum pressure and no more of 15 of PEEP. After that, and it's one thing that I'm changing my practice in the last year, I don't go down in pressure control anymore, especially in children. Because if you keep a driving pressure of 15, you will see when they go down that you give a huge amount of tidal volume. So in this area, now I change to volume with a fixed tidal volume of 6-7 milliliters per kilo, and then I find the point that they have lower driving pressure. It's another thing that I'm changing my practice. Obviously, I focus in dynamic compliance, but it's better to focus in the point with lowest dynamic compliance. Okay, I'm finishing, only 3 minutes. Resistance. Why is so difficult for any anesthesia machine to ventilate a preterm baby or a neonate? This is the reason. All the children had a huge amount of resistance because the airway and the tube create a lot of resistance against the resistance of the flow of the machine. That's why traditionally it was so difficult to ventilate children. That's why we went to Mappesson system, TP series, and all these kind of things. So remember, whenever you are going to ventilate a neonate or a preterm baby, be careful about compressive volume, tidal volume. We don't have time to explain that. But be careful to hypoventilate your patients. Okay, so take-home message on time. In my opinion, this is the most 4 crucial points to remember before ventilate any children. And of course, the smallest the children is, worse for you and worse for the machine. First of all, neonatal lungs have low functional residual capacity, high closure volumes, so neonates are prone to have atelectasis. Always, always, always. They are perfect models for this reason, to study and to see the benefits of recruit maneuvers and set individualized PEEP. Second, low pulmonary compliance, very tough lungs. You have to remember that. High airway resistance, very difficult to ventilate for that. And finally, neonatal lungs are the most critical and hardest proof for any anesthesia machine. That's one thing I always recommend to you. Even if you are adults, anesthetists, and you are not going to ventilate a neonate, never ever, ask that this machine pass the proof or pass the test let me say like that they can ventilate safely, even neonates. And that's for all of you that really wants to get deep in mechanical ventilation. We have a course there in Madrid for 2 days, only 2 days. I have an honor to one of my best co-director for one of the first courses was Javier Saber. And Manuel Foutier, Paolo Pelosi. So save the date if you want to, and thank you so much for your attention.
Thank you, Professor García. Very inspiring. Thanks for the tips and hints. I know it's very hot in here, and that's not just because of the hot topics, but I really apologize. Are there any questions that should be answered right now? If you have a question, please step up to the microphone, please.
It's Dr. Khalil from United Kingdom. I'm not a pediatric anesthetist, but I do deal with kids in the emergency situation, particularly neonate and newborn. And I have not much experience, but obviously I need your opinion. Regarding the FI2 and the effect on retina, on the damage on the lung, is it time dependent, or it is just 5 minutes and you get the damage? Have you got evidence for that? Thank you.
Thank you so much. My approach about VO2 is, all your life have the experience that whenever you apply a high concentration of VO2, the timing to recovery, especially in a cardiac arrest, you recover the patient is shorter. So my point on that is go for the things that is going to make shorter the situation, because this is true. This is what you are doing your daily care. And now we know that if you use, because the problem of, clinical trials is wonderful, is the way to improve. But the retinopathy clinical trial was exposed the children more than 50% during 28 days. So as far as I know, maybe I'm wrong, but as far as I know, even the animals and the experiments in animals, nobody has shown that you create any damage for 3 minutes of high VO2.
What about few hours? I'm sorry, I'm just because I don't want to feel guilty of causing damage unnecessarily.
I know. That's. I'm sorry if I've been too much passionate, but imagine this is 150 deaths, 20,000 deaths. Our practice so far, that is true, our practice is true, show to us that apply in the cardiac arrest or in acute hypoxemic event, high doses of VO2 is good for the patient because you recover it faster. So my approach is, obviously now we know that more than 70% in this specific, I'm talking about only preterm babies, even in term babies is not that clear. Only in preterm babies, we know that if you apply VO2 or 100, you create problem in retinopathy and in the lungs. So the only thing I do, I go for 70 because there is any evidence to use 70 versus 100, you are not going to recover the patient faster because you don't increase the oxygen content in the blood. So go for 70 because it's a perfectly safety area. And whenever the patient is recovering to the objective, let's say neonate 41, 48, I reduce VO2 and to keep this saturation.
Thank you for your
Thank you. Thanks to you.